I'm going to wing it.
Gary, I got you, and we can chat.
Okay.
Whatever you did for me worked fine.
So I won't be reading the instructions after all then?
I think you will. It'll either be you or Guillermo. So I think.
Okay.
Did we lose Lauren?
Perfect timing, right? All right.
Okay.
Thanks. Sorry, all. Ben, if you want to let everybody in, that would be great.
I will
Thank
do that.
you. And I think we're
I'm going to resume the recording too.
Live on YouTube. All right. Thank you. So welcome everybody to the 24th Community Advisory Group meeting. We are able to share this live in English and in Spanish, and have American Sign Language interpretation and closed captioning. If our interpreters in Spanish could announce that we'll have live interpretation, that would be great, and then I'll turn it on, please.
Buenas tardes a todos. Buenas tardes a la 24 Junta que está presentada en vivo. La siguiente presentación tiene servicio de interpretación al español. Y para iniciar esta función, por favor, haga clic en el icono de interpretación, el símbolo de un globo o mundo. Y número 2, seleccione español como su idioma. Opcional, para escuchar solo el audio en español, haga clic sobre Mute Original Audio.
Thank you. Let me get that set up quickly. And then we can get started. Thanks everyone for your patience.
Muchas gracias a todos por su paciencia. Ya mismo vamos a comenzar.
Oh, shoot.
Thank you, Lord.
Sorry. Oh, okay. I will kick that off and troubleshoot later. Okay, so I will pass it. Let's see. Yes, we have in Spanish and closed captioning, and I will pass this over to our one of our co-chairs, Nestor Castillo.
Thank you, Lauren. Do not worry, you're doing a great job getting us started here. Welcome, everyone. Happy Tuesday. Good afternoon. I'm happy to see everyone here on this wonderful, beautiful day. I'd like to welcome all of you on behalf of the co-chairs tonight. I'll be doing it solo. I think Kimmy, Director Watkins Hart, will be joining us maybe a little bit later, and our other co-chair is out for the evening. So you will be riding just with me tonight, and some of the other wonderful facilitators that we have, of course. Just so you can get a sense of what we will be doing tonight, we're gonna start off, as we always do, with a little bit of partner updates, right? So if those of you who are out in the field doing work on the ground, if there are any updates that are important for us to know, or for other of the participants to know, that you please share those with us. Then we will jump into a little bit of a county update and discussion, where we will have a little bit of a chance to kind of discuss some of the latest updates. As some of you, or maybe all of you, have heard, right, that there are some changes at the county level that are of importance for all of us as participants here. And then we'll transition from that county update to a little bit of that strategic refresh, the small working groups that we did last time around. And so we'll be working in small groups. I think we have a good enough number of participants now where we can break into a couple of working groups and then come back as a large group and share. I have to remind myself also to slow down for our wonderful interpreters, so I'm not losing anyone. And then we'll close out as always, right? How does that sound? Does that sound good? Any friendly amendments we would like to make to the agenda? I don't think that we can, because we're on a sort of a tight schedule today, but it's nice to at least have the opportunity to do so, right? Even if we can't do it. Okay, why don't we start with, since we're on a tight time schedule, because I think there will be a lot, or at least some active discussion I expect after we have our once we jump into our county updates. Why don't we start with some updates from folks? What are we hearing? What is new? What has changed? What are folks hearing on the ground? And as always, if we're sharing, if other folks are sharing, please try to keep your mic on mute so that we can hear clearly the folks that are presenting. So who would like to kick us off with maybe an update?
Hi, good evening. It is Dr. Donna. Hello, everyone.
Hi, Dr. Donna. I didn't recognize you from the fantastic image that you have right now.
You didn't recognize me from season 4? Yes, sorry. So we, Truvine, we're still doing vaccinations with Umoja. They're coming to our site every other Friday afternoon, and we're continuing to do that. We're seeing, a decrease in the number of folks who are interested in getting vaccinated, and definitely a decrease in folks who are interested in even getting tested. But we're going to continue to offer the services for people who are interested and do need a vaccine in West Oakland. They can come on Fridays from 12 to 4, every other Friday on 12 to 4. So not this Friday, but the following Friday. And then on a personal note that is leading to a professional note is I wanted to call out how our county is really eliminating barriers for our test to treat. I had a personal experience last week in trying to get my husband tested and treated, who I would consider high risk. And there were a number of barriers and a lot of confusion in multiple sites about who is high risk, whether or not there's a physician on site when you go to a test to treat site, whether that physician deems the person there high risk. So I do think it would be great if we could put this on the agenda for another night when it's not so packed, that we really look at the equity and the barriers around our test to treat sites, the availability of our sites in our county, and really making sure that we have the correct information for people to know where to go that's actually a test to treat site. Some places I called that were on the test to treat list were actually not test to treat sites. So I would like to just call that out definitely, because we need to make sure we have low barriers and that the people who are truly high risk are getting the treatment that they need.
Thank you, Dr. Donna. We will definitely put that on the agenda for the next meeting with the co-chairs, but I also want to give anyone from the county a chance to respond if they feel they have maybe a quick and brief response to that. If not, we can schedule it for a future meeting to have maybe a robust discussion around.
This is George Nestor. I'll just say that Dr. Don, I'm really so happy that you brought this up. We absolutely have to have a conversation about how we lower barriers or eliminate barriers. There's still a lot of confusion. I also have a personal story about this. And so I feel a personal and professional urgency to kind of bring this to the table. So thank you very much. It is on our radar, and we join you in your concern.
Awesome. Thank you.
And if I may, it would be wonderful, since groups are now going into our communities, particularly our high-risk communities, that we have uniformed messaging that we can do in our door-to-door, in our coalition work, when we're actually out on the ground, that references the test to treat. A lot of people are, to my knowledge, seemingly unaware that a lot of that is happening, particularly in, again, the hard-to-reach communities. So if we can coincide the county's work with getting messaging to be able to put in the hands of people when we're on the grounds, that would be fabulous if that timing could work out.
I completely agree, Gary. Thank you very much for that.
Aaron Ortiz from La Familia. I do want to make an announcement that La Familia is moving forward with becoming a test to treat site at both of our stationary sites. So that's something that we're looking at rolling out, I would say, in the next week or so. So we've been planning this for a few weeks. It's taken some time, but we're going to roll that out. The other exciting announcement, we definitely want to acknowledge our partner Roots and Dr. Noha for partnering with La Familia and doing vaccination clinics at her site, and also that our coalition partners are going to be involved in, such as Street Level, Homies Empowerment, Tribe, Unity Council, and I don't know if I missed anybody, Gabi.
Oakland Collective.
And of course, East Oakland Collective, yes. So just wanted to let our team know here. Thank you.
Thanks, Aaron.
Thank you, Aaron. I think we have at least a minute or two for maybe one more partner update or announcement.
Oh, go ahead.
I saw, yeah, let's start with Sandy and then jump to Dr. Noha.
Hi, everyone. I'm Sandy. I'm from Street Level Health Project. I just wanted to bring this to attention. So recently, we have been, since the announcement of in-home vaccinations, we have experienced some issues with it, with the language access. There's not a lot of option for the different languages that is accessible in a vaccination. So yesterday I was trying to help a community member, and the only options that it says is English and Spanish, which is, I know it can be a barrier for other communities. And also with the Spanish, it takes longer than for someone. When I was trying to do Spanish, no one answered me. It took, I was waiting for like 10 minutes and it automatically just says, there's no agent currently taking your call, please call back, or it tells me to go to the website. So that's a huge barrier for a lot of community who only speak Spanish. For the English one, I tried English and it was more accessible. I didn't wait long. So there is a huge barrier right there. And so if we can fix that or find also on top of that, have more language accessible, that would be very helpful for other communities.
Thank you, Sandy. We'll make a note of that. It sounds like we will most likely have a very robust discussion in the next meeting or very soon around removing some of those barriers and accessibility, which is sort of coming up as a theme. Dr. Noha?
Yeah, I was just going to chime in to say that we're definitely seeing a lot of positives right now, both coming into our testing site as well as, calling in, having had tested at home. And one of the things that we're really trying to emphasize is that it is possible to stop spread within the household. So really trying to give people the tools and information that they need to isolate within the home, because we have been having some success with that, with people being able to stay negative, especially now with, you know, folks being better vaccinated and things like that, so that they shouldn't just kind of throw their hands up and assume that everyone in the house has to get it. So I think that that's a really important goal. Also, you know, I think the enthusiasm for boosters isn't quite where we would like it to be. We still have a lot of folks that haven't gotten their first one. And we're definitely concerned about some of our elders who just are like done and don't seem to want to get the next one. But, you know, trying to really share without being too alarmist that we still are losing people. And some of them are vaccinated, but that the booster does seem to be making a difference. And so wanting to, because I think it's still kind of confusing out there. People are just not really too sure how important it is. There's like a lot of mixed messages out there, but particularly given that we are, you know, in a surge, even though it's hard to maybe tell compared to before because of, you know, not being talked about as much and so many people testing at home. I think we do need to get more creative on how to demonstrate to the public that we're in a surge. And I just really want to appreciate our public health officer for, you know, reinstating the mask mandate, because if nothing else, that did give the, you know, clear message that we're in a surge, we're concerned, we want people to be protected. But I think right now, like Omicron scale threw everything off and makes everything else look small. That doesn't mean we're not in a surge. And so I think we do need to have ways that we can show. I know that on the county's briefing not long ago, it was stated that for every one laboratory confirmed test of positive COVID, there's like 7 or 8, someone can correct me if I got the number wrong, 7 or 8 home tests that were positive. That's pretty striking. And if people knew that, I think it might make the difference in how they're thinking. The last thing I'll say is that a lot of people seem to feel like no one's dying from COVID anymore, but at least by my count, and I'm literally counting on the dashboard, 38 people have died in Alameda County since April 1st. And I don't think a lot of people maybe recognize that, and that is still significant. And I think it's a good goal for us to be shooting for 0 COVID deaths. And so that is kind of what I've been saying is 0 COVID deaths. We shouldn't lose anybody else from this. And so the last thing is just really underscoring what everyone else said about the test to treat. There's a lot of barriers. People need to understand to advocate for themselves. They shouldn't get denied because of a certain medication or something. Maybe they need to hold the medication. Maybe they need to go to a second line medication. But if someone is high risk, we've also been hearing primary care doctors saying, oh, if you're not feeling that sick, then you don't need treatment. That's not how this works. The treatment plan should actually be created now when you don't have COVID. You're either someone who should get it or you don't qualify. So that's something that should be arranged with the primary care doctor ahead of time, not like wait and see how you feel, because that's not actually how this works. It's really the sooner that you started, the better. And by the time you get too sick and have to go to the hospital, it's too late. So wanting to make sure that people really, really understand that so they can advocate for themselves, because unfortunately, it's not that straightforward still to get the treatment. Thanks.
Oh, thank you. I just want to say thank you. Seriously, these are the things that people don't hear about and don't get to, especially communities of color.
Yes, thank you, Dr. Noha. And I think that's actually a great place to transition over to Deputy Director George Ayala to get the county update. You mentioned a little bit about the masking update, and so we'll touch on that as well. But I want to kick it over now to Deputy Director George Ayala.
Thank you, Nestor. We are definitely in a summer surge, and I actually think I can't queue up the next section better than this, the set of comments that we just received. And so with that, you know, we are in a moment, we are in a different moment. COVID continues to evolve, and we need to evolve with it. And we have to kind of push back misinformation campaigns that are out there. And we have to keep advocating for communities of color and other vulnerable communities, because if we don't do it, who else will? So with that, I'm going to pass it to Dr. Moss, who's going to give you an update, and then he'll pass it to Donata Nielsen, Dr. Nielsen, who will give us an update on some of our county response, and then we'll have a conversation about masking. Dr. Moss?
Thanks, Deputy Director Ayala. Yeah, just very brief update on the numbers from me, one slide only. So we're at 54 cases per 100,000 residents per day. This is, we look at this with a week delay because of, it takes about a week for us to start feeling confident in our case reports. This is the highest point that we've had throughout the spring wave. So this number hasn't started to drop yet. I hope it does soon, but we're not seeing that in the case rate yet. About 10% test positivity, depending on which day you're looking at. It is, both of these numbers have risen steadily up together. Still a fair amount of testing being done, a little bit lower since Memorial Day. Maybe that's summertime. Sometimes one holiday can throw things off for a while because we look at averages. So I think we still get good information about what's going on in Alameda County, but what Dr. Abelada mentioned is right. It could be as many as 8 times as many cases as what we're seeing in the official numbers, or 8 times as many infections, I should say. So, and then hospitalizations, we're up at 124. We were at our spring peak yesterday at 133. It will bounce around a little. I think the overall trend has been continued increases. ICU has increased up to 18. That's the peak for the spring so far. And now I just checked before this call, it's actually 41 deaths since April 1st, Dr. Abelada. And we have not seen the deaths from the latest weeks of increases yet, right? So hospitalizations really started to climb at the end of May. Any deaths we see from that period, I think would probably not quite be showing up yet or just starting to show up. So I really don't know how high this number goes, but certainly I think we feel like it's necessary to be responsive when community members are dying. And we're in CDC high community levels, that's the orange, on their most recent, the current CDC community risk measures. And I'll turn it over to Donata for her update.
All right. Thank you, Nick. Go ahead and go to the next slide. I just have 2 quick slides. I wanted to give everyone just an update on our ongoing COVID division work. We are right now continuing to prioritize our 65 and over, 5 and under, and we continue with the 12 zip codes to screen for the ARCH stipends. We have about 175 ARCH stipends left at this time. And I just want to put a big shout out to our CBOs who have been just amazing partners in our response. They've helped us with our case investigations, contact tracing, outreach, health education. We did the isolation care kits, and now they've helped us with case closures. So it's been just a wonderful way to work with all of you and augment our response capacity. We are continuing to see outbreaks in every setting that we are investigating, in workplaces and schools and everywhere. We, of course, continue to prioritize. We are also continuing to see vaccination needs at workplaces. Some workplaces have requested vaccination clinics, so that's great news. Our case investigation and contact tracing will continue to support our priority outbreak settings. Right now, we still have some state staff. We have some disaster service worker staff from our agency, as well as some CBO staff still helping us. But once those wind down at the end of June, our case investigations will pivot a little bit to focus more on supporting outbreak investigations. And then, of course, we're also going to pivot, as was mentioned earlier by Dr. Donna, focusing on access to treatments with the team we have in the COVID division. Next slide. And then just a quick update on testing and vaccination. So we are just at about 91% of our population has had 1 dose. Just again, with the understanding that our youngest population, the 6-month to 4-year-old, isn't quite eligible, but we're looking forward to having them being eligible in the next couple of weeks. Our Alameda County is really a leader in vaccinations at our SNFs, and in the nation. We are at about high 90s compared to California's in the 80% range, and the nation in about 60 to 70%. So we're doing a really great job reaching out to our skilled nursing facilities. And just a reminder that we want to make sure to reach individuals in our communities who remain unvaccinated. So we will be transitioning from our stationary sites to really be as flexible as possible to do pop-up events where people are in the community, as well as expanding our in-home vaccination opportunities. But just to go back to our long-term care and SNF, we've had over 190 clinic requests in just 8 weeks. We've completed 109 clinics and almost 2,000 doses administered. And then briefly for testing, our testing site utilization has been increasing. This information is from the end of May to early June. We've also seen much higher positivity at our testing sites. I think Dr. Mouse mentioned about 10% in general. We're seeing about 18 to 19% at our testing sites. The OptumServe sites are fully operational and providing test to treat program. And then we are also working on some internal, potentially having an internal nurse call line to, and working with our healthcare system to provide access to treatment in the coming weeks. And that is my report.
Thanks, Sonata. I think it's back over to you, Dr. Moss.
Thanks. So next slide, please. Just a quick reminder, this new masking requirement went into effect on 6/3, masking in indoor public settings, a little bit very similar to our last masking requirement with a little bit more flexibility. We're trying to be able to bend, not break, take the pressure off some of the hot button points that had emerged in the past. It was always going to be a steep hill climb because we knew that other jurisdictions, even locally, were unlikely to do something like this. We may see LA at some point, but I don't know that we'll see others follow suit anytime soon. And also just because we know that many people are tired, and even here, not everybody has embraced masking. Next slide, please. So the goal of the requirement is simply to get more people in masks for more time in indoor public settings, to try to bring about an earlier and lower peak of this spring wave of infections. That's really what we're trying to do. More people in masks to try to end the peak. And by doing this, we think that we're going to increase overall protection for those at greatest risk of poor outcomes. Look, maybe we're all going to get COVID multiple times in our lives, but in a wave like this, the risk is extremely high. And as we heard at the start of the call, there are still barriers for people, and we think that giving people more time is appropriate, at least at this period where there's just so much COVID around. And by doing that, we think we'll reduce some of the community impacts of severe disease. Next slide. What we've said, I want to be clear, this is not something that's going to be around for months and months like we had before. I certainly don't think we can sustain that. And my hope is that we do see this wave start to wane shortly. So when we see a sustained decline in our daily case reports, we're going to lift this. Masks are still going to be a great tool, but in terms of keeping a mandate in place under that situation, be very hard indeed. Our case data is preliminary for about 7 days, so we're not going to rely on that preliminary data to make a decision like this. We'd only consider it if we had a lot of other corroborating data. Lifting the requirement too early will weaken its effect. And so, we could spend a lot of time on timing of this, but we wanted to cover some other aspects tonight. Next slide, please. So Hopefully this group will be familiar with these concepts and why we are focusing so much on masking. They've been an important layer of protection against COVID really throughout the pandemic. They are a low barrier intervention, and we are working to get masks out there as you've heard before, for people for whom there are barriers, especially to getting those higher quality masks. Vaccination has been great. We are huge believers in vaccine. Of course, we talked about a lot on this call, and vaccines have proven their ability to prevent severe disease, including in our data during the winter wave, and more so with boosters. But vaccinated people can still spread COVID. Everybody knows that now, I hope. And some vaccinated people get seriously ill. And there was a time, so the risk, if you're vaccinated, especially if you're boosted, of going to the hospital or dying is much, much lower than if you're unvaccinated. But virtually everybody's vaccinated here. And we are seeing that people who are vaccinated are still ending up in the hospital, and they're still ending up dying. And in fact, we'll touch on this again, but it's not trivial. So this isn't about, well, people haven't got vaccinated yet and they're paying the price, which I don't think we would use to guide policy anyways. But this is just about the fact that they're not perfect. And we need to keep doing things to protect public health beyond rely just on this one tool alone, at least when there's so much COVID around. I think you hear a lot of criticism of masks, but their actual benefits far outweigh their downsides. And we'll talk a little bit more about those things. Next slide, please. And we wanted to have this conversation here, I think, because it's important for people to realize that some of these myths have really, the conversation is very different now than it was in a lot of spaces. People don't want to think as much about COVID. They know there's a lot of it around. We talked about how the rates are sort of, don't capture how much COVID is around. And I think the messages that are kind of circulating, certainly the stuff that gets reflected back to me from a lot of people in the county, are some of these myths that I think unfortunately have been, shown up in editorial pieces and in newspapers and things like that, but actually don't really reflect our understanding of the science. So first of all, masks stop the spread of COVID. COVID is airborne, spreads easily through the air. That's far and away the way people get it, not by touching, much less so touching dirty surfaces or things like that. And masks can prevent people from being infected, especially if it's a high quality, well-fitting mask. And there's plenty of evidence to suggest that when people are wearing masks in indoor settings, that can be protective as well. But not just that, but people have also looked at just trying to track using survey data, how many people are wearing masks in the community, and have shown that higher levels of mask use are associated with decreased COVID transmission, even when you adjust for things like how much people are staying home and stuff like that. And so, so actually the evidence for community-wide masking is there as well. Next slide, please. And this is just a recent really nice paper done right here in California by the California Department of Public Health, published by the CDC, showing that the better the mask, the better the protection. Although you see, even a cloth mask did show some benefit in this study compared to no masking at all. This is the risk of people getting infected while they're wearing these masks. Next slide. Another thing that we've been contending with is this idea that requirements don't work. People won't follow them. Well, it's sort of a self-fulfilling prophecy. If people are told, oh, requirements don't work, and then they don't wear their mask, then you're not going to have people unmasking. And we do depend on voluntary compliance, but that's why it's so important people really understand some of the truths behind these ideas that have been floating around. Alameda County has proven that it's a very mask-friendly community. We had very high rates of masking, both in our survey data, but I think everybody who's gone out and about in the Bay Area has seen that with their own eyes throughout the pandemic. People really have embraced masking here in a way that has not been true in other places, which means this is a place where mask requirements, getting people back in masks can work. Maybe they can't work in places where there just isn't the public buy-in, but we've had very strong buy-in of public masking in the past, and we need to try to sustain that through this current wave. We actually followed this survey data regularly. We have seen an increase from the mid-60s to the mid-70s% of survey respondents who have reported wearing a mask in indoor public settings with this latest requirement. Now, this sort of thing has its limitations, and we're the first to admit it, but it's really reflected what we've seen before in Alameda County. And it's exactly the kind of data that those studies I mentioned before that look at community mask wearing. It's the same data that they use to do those studies. So I think it's a good sign, first of all, that this is a place where masking is continues to be strongly embraced, and that we can feel confident that what we see in our numbers reflects a public health benefit. Next slide. Masks are safe. Believe it or not, and maybe everybody on this call already believes it, when you hear people questioning the safety of masks, there isn't really good data to back up those assertions. And when people have done good studies to look at mask safety, they've generally found that they're very safe. And so not just that, but we have, the American Academy of Pediatrics continues to recommend masking for children 2 and up when COVID transmission is high. There isn't clear evidence of masks impairing emotional or language development in children. They haven't been shown to negatively affect oxygen levels or kids' ability to focus in schools. Things that you hear thrown around, but just aren't accurate. And another thing I would add here is, sometimes masks are linked to mental health challenges that children have had, but I haven't seen any evidence suggesting that it's the masks that have caused challenges that our children have experienced during the pandemic. And I think you really have to view it, the overall context of a pandemic that's killed over 1 million Americans and disrupted the lives of so many people, including children's. To hang that on masking without evidence, I think is problematic. Next slide. I mentioned this before, but I think one argument we hear is, look, I'm protected, my family's protected, people who aren't protected yet, that's their choice. But public health isn't about choice, it's about things that we do together to try to protect people, particularly those who are at greatest risk of the worst outcomes. We're seeing people in the hospital who are fully vaccinated. I think it's something like 2/3 of our hospitalized residents in May. We haven't done the formal analysis yet, but that's what the numbers show. And I think also concerning is that we're seeing deaths among vaccinated people. And again, this isn't because vaccines don't work. It's because everybody in the county above the age of 50 is vaccinated. But vaccines, as good as they are, we're still going to have this problem where there are some people who are still not fully protected, either because of their age or their underlying health status, their immune system. And when COVID risk is this high, I think we have an obligation to try to protect those people and give them some more time to get protection, just some more days. And so I think when people say, well, it's just the unvaccinated, you just have to remind them that it's actually, it's everyone. Next slide, please. And so we're trying to figure out how to socialize some of these messages, and we thought this would be a great group to do it. Really interested in hearing some feedback about it. And I'm not sure if somebody else was jumping back in to facilitate at this point.
Dr. Moss, I wonder if you could say more about the disparities. I know that that's something we've talked about here a lot that we were going to be paying attention to. I don't know how many health officers are paying attention or reacting to, but I wonder if you could speak to that.
Yeah, so throughout, I didn't have a slide on this, but throughout the spring wave, we said that we were going to look at the impact of severe disease and the reemergence of disparities as consideration for implementing a new mask mandate. And so with the severe disease is there, at least if you're looking at our hospitalization and now our intensive care unit numbers, our hospitals, I don't think are under strain, although I don't think it's easy yet. The numbers are still going up, but clearly people are getting sick. And of course, we mentioned the deaths. But also what happened is earlier in this wave, we saw primarily, so the highest case rates in our lab reported data with race ethnicity, which is about 7,000 or 8,000 lab reports per day. So a lot of data, certainly not every infection in the county, were among people who were reported as white or Asian. Now, I know these are very broad groups. We've talked about this a lot before. We don't adequately disaggregate our data, but this is sort of the reverse of the pattern seen in prior waves. That changed. Now in recent weeks, it's really the highest case rates are in people identified as Latino, and that is a trend that started earlier in May, and that where the numbers were going up faster among Latinos and other groups, and now now we're seeing the highest rates. So now we have return of disparities, previously hardest hit population in terms of infections. Again, with the highest rates and severe disease. We don't, in terms of, so I think it's too early to look at deaths. We're going to need to wait and see really what the impact of this wave is to have a full understanding. And hospitalizations also, we don't have a lot of data yet. So I think it's just, the data even for May in terms of race, ethnicity, and things like that, that takes a few weeks to come in. So I think we need to really wait on the hospitalization data, probably maybe later this week or later this month, we'll have a better sense of who's getting hospitalized by race and ethnicity. But I should say, in past waves, the patterns have been very clear that there are disproportionate impacts in terms of severe disease on communities of color. And I didn't mention some of our smaller but very hard hit communities, Pacific Islander and Native American communities, where because the county populations are much smaller, it's a little harder to look at the data and feel as confident in the numbers because they can have big swings from day to day. But those communities also very hard hit, disproportionately so.
Hi, Dr. Moss. It's Dr. Donna. I wanted to, I think it's a tricky conversation to have, right, around vaccinations. When you say get vaccinated, but even people who are vaccinated are getting severe disease and hospitalizations. So for me, that's kind of what I've been talking to a lot of people about who are still either not vaccinated or not getting their booster. And so I think coming up with some sort of a good message to deliver around that piece would be really valuable for the community.
Yeah,
so
I agree.
You have some thoughts on that?
Yeah, I mean, I agree. I mean, this is really challenging, but I think, first of all, I get asked this all the time. I can't tell people, I have to tell people what the numbers are showing. Right. And I think that it is difficult. So first of all, we don't have the booster data yet. So I don't know how protective, I don't know if those people who are fully vaccinated were boosted or not, and how that is impacting our hospitalization and death numbers. But I do know that during the main winter Omicron wave, boosters were very protective, that the lowest death rates were among people who were boosted. The next lowest group was people who were fully vaccinated with their primary series, and the people with the highest rates were unvaccinated. And I believe that pattern is likely to hold true now as well, that the greatest protection against severe disease is if you're boosted, particularly for those at highest risk. And if you're fully vaccinated, you have some protection, but better get that booster. But I think it is important when the argument we're hearing from people is it's just unvaccinated people ending up sick. And that's why you shouldn't
Say it again.
require, when the argument that I get from people, well, I don't know if that was a question directed to me. The argument that I get from people is that it's just unvaccinated people getting severely ill. And we shouldn't require people to wear masks in indoor public settings. Then I think it puts me in a position where I have to be transparent about what we're seeing. So I understand it's a difficult message, but vaccines are very protective. They protect people against severe disease, but there are going to be some people at risk despite that, and we need to do more to protect those people.
Yeah, I absolutely agree that what the information that you just stated about who was, vaccinated and boosted had the least severe disease. Do you have that on a slide that we could share?
Yeah, I do. We've only they're kind of hot off the press, and I haven't had a chance to even use them myself yet. But yes, we should be able to start circulating those. And feel free to email me in case I forget.
Okay,
the state dashboard. Oh, sorry. I was just going to mention the state dashboard they've been maintaining also, and it's still showing like more than 8 times more likely to die for unvaccinated compared to vaccinated. So that graph, Dr. Donna, I have found actually pretty helpful. I'll pop it in the chat too.
Awesome. Thank you.
So I think it would be very helpful if we also start centering our messaging around the symptoms of long-term COVID. A lot of our people are somewhat, I'm not going to say naive, somewhat unsure as to what those symptoms are, and they could be experiencing them. And again, I'd love it to coincide with our boots on the ground, that we pass that information along also, where individuals may be experiencing the symptoms and be unaware that it is a byproduct of COVID. And I think if we could generate that type of messaging, it would be very helpful, particularly now that our people who may be suffering from them may have difficulty going back to work and or proving that it is COVID related.
Thank you, Gary.
I agree. Go ahead, George. Sorry.
No, please go, Dr. Moss.
I was just going to agree and say we need to help support you all to have better messaging around this. I think it's it's for real. It's a serious problem, and it's going to be with us for a long time. And we need to start improving our messaging.
Thank you, Gary, for that question. Gabriela, I see you.
Yes, thank you. So similar to what Dr. Donna was saying, I also want to make sure that our messaging is clear. I think we need to be careful when we say everyone's going to get COVID. Well, that may be true. It sends the wrong message. We've had a lot of community members who hear that and say, okay, well, if I'm going to get it, then I don't need to protect myself. So I think that's part of the problem. And also knowing that communities of color, may be suffering chronic illnesses. Like, Gary said, we still don't know the long-term effects of COVID. And just, as much as we can try to avoid it, and, because not everybody has the same privileges of staying at home, having health insurance, paying for medication. And so I think just being aware of just that messaging and maybe not saying it in that way, or finding a different way. And just, it reminded me of actually Dr. Noha's briefing where she said 40% actually of the US hasn't gotten COVID, right? So I think I keep hearing that kind of messaging, and to me, it kind of alerts me because of the community, just it doesn't land with the community in the same way.
Yeah, I mean, I totally understand that. I think it's important for people in this forum to realize that this is the dominant message that's getting out, even among experts. People are not helping us in the public space by saying, look, we need to slow down infections. And so, we're trying to do it with the mask requirement, but the the message that is out in the, at least what we're hearing back at the department is like, why are you trying to stop COVID infections? And so, you know, I think it's going to take some work. And I'm sorry if I'm like echoing that message, but I think it's important for people to hear that that is in fact the argument that is made. Why have a mask requirement? And so far that is a very, I mean, you know, we're going to need some help if we're going to.
I see you, Aaron.
One thing I've been saying is like, if I have to catch it, I'd rather
George, did you
catch
call
it
on me?
later when we know more about it and we
You did?
understand
Okay.
like how to treat long
I can't hear you,
COVID or
but I
prevent
hope,
long
I hope you
COVID.
can hear me.
So I'm in the delay
I think,
camp.
Aaron, do you have the next? Okay. Do you have the next hand?
Dr. Moss, first of all, I want to thank you for your
It's
leadership.
not
but
like you
before I
just get
there-
it once and you're done. You could keep getting it.
Oh.
And every time you get it, it's another opportunity for a bad outcome or for long COVID. So I feel like those two things are points that could be brought up.
Yes. Can you hear me, team, by any chance?
We can hear you, Aaron.
Okay. Sorry about that. Thank you, Dr. Noha. And, you know, Dr. Moss,
Yeah.
I want to thank you for your leadership, but also I want to echo some of the same sentiments that Gabi brought up, especially the words of we're all going to get COVID-19 maybe, right? And I know I've heard you say those words, and with all due respect, I'd probably be a little bit careful to use those words just because it could probably get caught up in a soundbite. And people say, well, hey, you know, our public health director said we're all going to get it, so why even care about using a mask or whatever else? But I want to thank you for your leadership when it comes to putting the mandate back in place with masks. You know, I think the key right now is, you know, we're trying to all save lives, right? And I think with your leadership, that's the key behind the mask, especially for people that have, and of course I'm preaching to the choir here, but that have underlying conditions or any other medical conditions that could be severe to their system. But with that said, I mean, I'm just going to be very frank. I mean, I think if politicians or anybody else is going to talk about, you know, masks or anything when it comes to, you know, medical opinions, they need to talk to a doctor first and be very objective about the information they're giving out there. I'm just putting that out there. And I think the other key too is, I think as a society, we need to be agile. I mean, Alameda County has twice the population almost as San Francisco. We're a very, very dense county. And with that in mind, this is the reason that we have to have a mask and we have to be agile. There's going to be periods of time, I'm sure you'll agree, Dr. Moss, you know better than I do, that we will not have to wear a mask during some months. Some months we will, till we finally get a hold of this. We're not even at a point where we're calling this an endemic. We're still making sure that therapeutics work right. You know, whether it's, you know, fine-tuning vaccines or if Paxlovid, you know, can be the answer to be a pill that you can pop, where this may be, you know, less than a cold. And I think lastly, we all need to ask ourselves if we want to have ripples or if we want to have waves, because when we don't do this, you know, this is the outcome that we have, is a lot of people catching COVID, and especially people of color that are impacted and lose their lives. So I'll pause there.
Thanks, Aaron. I see you, Carla. Thanks for waiting.
Yeah, thank you so much for the opportunity. And thank you so much, Dr. Moss, as well, for all the updates. My question is in regards to the public health emergency. And I was looking at the May revised and I found in there in the health section that I believe the public health emergency is set to expire on July 15th, if I'm not mistaken. And as we know, many of the resources that are coming to the state or to the county depend on this public health emergency. And I know as well that the administration is supposed to announce at least 60 days with an advance notice before ending it. So I would like to know if you have any federal developments or state development updates in regards to this. I also have seen that it will be likely extended to October, but it's nothing official. So I'm just trying to figure it out, so we can prepare in advance to anything, that will affect our policy decisions in Alameda County.
If somebody else has more up-to-date information, please share it. So there are a few federal emergencies, but my understanding is the most important ones, it might even be a 90-day leave for that. So we're looking at into the fall, and it may not be official, but I think they have to go into the fall. So it may be, I can't remember if it's the end of I can't remember if, you may be right, it may be October. So I don't think that's imminent at the federal level. And then for the state, I don't know for certain what the plans are. I know they've signaled in the past that some aspects of some state orders would roll back at the end of June, but whether the state declaration would roll back at that time, I don't know. And maybe the 60 days is the state thing, but it's a few weeks away, and I have not heard anything to suggest that it was imminent. And, so I'm not expecting it, especially given that we're in a period of some of the highest numbers of infections that we've seen at any point in the pandemic, but I don't know for certain.
Thank you.
Thanks for that question, Carla. Come back in, Aaron. Jump in.
My apologies, that's an old hand.
Okay, thanks. Just checking. Doing a time check. How are we doing on the agenda?
I think if we need a couple more minutes, if I see Gary's hand, we can take a couple more minutes on this item, and then we can jump into the strategic refresh.
Thanks, Nestor. Come on in, Gary.
Appreciate you. Yeah, I really was wanting to reference Gabriella's comment in the chat. And it's now summer, and we have schools out, we have vacations, we have these concerts, we have the Warriors. I mean, but people are coming from all over, literally, from not just the state, but from all over the country, and then when you see the mandate, lessen with regards to international travel in our airports. And so what good is it doing if we put in mandates, if we lessen mandates, and if there is no uniformity when you look at it from a county, a state, region, anything, and my biggest concern is this: I can get in my car and be in 5 counties in less than a day, right? And it's just bizarre to me. And then, so when I turn on the TV and see all those people, at the basketball games and hockey or what have you, baseball, and then they just come out and they scatter all over the place, right? How are we contributing to the spread of the disease? And then how are we managing it, when we have activities such as that? And that's just a naturalistic observation point of view. I'm sorry, just had to bring that out.
No need to apologize, Gary. Dr. Moss, you have a comment?
Yeah, I think it probably the greatest challenge right now is that we're alone. I think that's as much one of perception. That aspects of that have been true for a long time, but I think Alameda County still did pretty well in terms of COVID outcomes so far, as bad as it has been here. Other places I think have been worse. But it's certainly hard when people, know that we're the only place with this kind of policy right now. And getting back to what we were talking about before, the de facto policy in other places is to let this play out and to focus on treatment. Really, I don't even think people are putting as much effort into vaccination as we are in some ways. and so we are not, it's no longer a, like the California approach or the Bay Area approach. It's really the Alameda County approach. And I know that this is, Aaron, I think your feedback is right about how people could use my comments in a way that's not how I intended them, but if it's just me out there, it's it's a tough message to push, given that other places I think are not as focused on this right now. They might be later. COVID has fooled everyone many times, and nobody can predict the future. But in terms of right now, I think we are. It's not about my words. I think it's about trying to get people to realize that this is important, and the more voices that can say that, the better.
I appreciate that, Dr. Moss. And in wrapping this part of the agenda up, I will say that I so appreciated this exchange. I was thinking to myself, people are really very polite in this group, and this is not a love fest. This is an advisory group. And that means that, we have to raise the hard questions in the interest of the communities that we serve. And people are respectful. We're all professionals here. Don't be afraid to raise those questions. Don't be apologetic about raising the concerns that you have. And to Dr. Moss's point, he is one voice, right? And given the challenges that we face in the state of California, and just kind of speaking to some of Gary's points, we need to do this together. No one voice will be able to address the concerns that we have, especially the concerns that we have about most vulnerable communities and communities of color in particular. So we can't do it by ourselves as the public health department. We need to do it together. I'm going to take Dr. Noha as the last speaker, and then we're going to move on to the next agenda item. Go ahead, Dr. Noha, take it away.
I just had a question for Dr. Moss as we're trying to get the data about deaths in this county and hospitalizations. Are we going to be able to find out if those folks received treatment? Because I think that first of all, it's important, we need to know, but that's also a compelling part of the story, right? If it's like the people who died, okay, some were vaccinated, some weren't, but none of them got treatment, for example, then I think it also raises kind of the level of importance, because the big rhetoric now of why nothing is being mandated is like, we have the tools, we have the tools, we have the tools. Well, people can't get the tools, it doesn't matter. And also we don't have the tools for long COVID. So I feel like, you're acting on the side of caution and responding to disparities in light of the fact that we don't have tools for long COVID. And we also, everyone doesn't have equal access to the tools. And until we know more, I think that it's definitely the right thing to do. And I think you should be seen as an example nationwide personally. But I guess I'm wondering if we'll be able to get that detailed of data, because I think that will help with our narrative as we go forward.
So yes, the short answer is yes. We're trying to do a review of deaths to see what missed opportunities were there. This is something you may have heard Contra Costa did like a whole press release about. We're trying to emulate what they're doing and even sort of comparing notes and things like that. But very early on, and I think we have a small team, and so it could take some time. And then I don't know how easy it will be to get to those answers. They have kind of like one large health system that does a lot of their care, particularly for higher risk communities, and we're not the same. But we're going to try, because we think that's important. What were the missed opportunities, and what does that tell us about what we need to fix?
Thank you for that question, Dr. Noha. Thank you, Dr. Moss and Dr. Nielsen, for your leadership in this section of the agenda tonight. And with that, I'm going to pass it back to Nestor.
Thanks, George. So with the about 25 minutes that we have left or so, we're going to actually move into the strategic refresh part of the agenda, and we may not get into a whole lot of discussion this evening, but we will maybe get a little bit of preview and maybe continue the discussion at our next meeting. So I want to turn it over to Julie.
All right, great. Thank you so much, Nestor. And I want to thank everybody for the discussion, the conversation, and echo what Dr. Ayala mentioned, that we welcome your criticism and your feedback, because we're here to reduce barriers and to care and to the support that our communities need. So thank you so much for that. That was a great conversation. So I feel like I'm pivoting from something that's very immediate and short term to something that's a little bit longer term, which is about our strategic refresh. And as you know, we've had a strategic plan that we developed in 2020. We updated it in 21. Last month when we met, we went through and identified some high priority areas. If you go to the next slide, please. There we go. So we sort of looked at some of the high level activities that we were doing and got your feedback from that tonight. The original plan had been to spend a full hour in breakout groups to really dig into priorities and where we should be putting our community resources. And that's just not just the health department, but really looking at the resources we have in our community and how we can best serve those to reduce the impact of COVID. So what I'm going to do tonight is to queue up that conversation, set the stage a bit. We'll go into our breakout group. So you can see the small working group developed a really innovative process to help get at what is more important and less important in terms of the strategies that are part of our strategic plan. We want to get your input into that, and we'd like to dive deep. So I think this will be, if we see this as a stage setting, you can get a sense. We'll break into groups very briefly, just long enough so you can get a sense of looking at the strategies, look at the little, we have these jam boards where you can move things around on higher or low priority areas. And well, we won't actually get to move things around probably that much, but you can see what it is, think about it, and then we'll come back next month to actually get the priorities and work those into our strategic plan. Okay, next slide. So briefly, to remind you where we are with it, the strategic plan has 4 big goal areas: to prevent COVID-19 infection, transmission, serious illness, which is what the mask mandate is all about. The second goal is to test, isolate, and support the care of people who are infected with COVID. Our third major goal is focused on racial and ethnic health disparities and reducing or eliminating those disparities when it comes to how COVID-19 is impacting our communities. And then the fourth area is around aligning and evaluating our public health infrastructure. And when we look at that, I want to think about not just the public health department, but how we are working together with community partners. We are all part of a public health system in this county. And as actually several speakers have said, we can't do it alone. We are working, we really want to work in concert with everyone. Next slide. So what I've done here and what I wanted to be very transparent about is within this strategic plan, this is the county's strategic plan, we identified a whole series of strategies that we're going to implement. The ones that are highlighted in yellow, these are things that the health department is in fact mandated to do. So these are things we're going to do, we have to do really no matter what. What we want to do, almost all of these, we do these, we seek out community input in a variety of ways. We take your ideas, but these are things, again, that the department is going to do regardless. The items that are checked here, these other strategies, are the areas where we really want to shape these based on your feedback and what we hear our communities telling us. We have a lot of more latitude to shape those kinds of strategies. So those are the ones we're going to take into our breakout groups to look at and prioritize, and also come up, if you have other ideas of different strategies, we want to get those as well. So if we had a little bit more time, next slide. what I wanted to do is just sort of break these down to look at what are some of the things that we've actually done. So this strategic plan now is about a year old. If you look at the actions taken, a lot of these, I think you're familiar with these. We did our, in terms of prevention. And again, this is not the entire list of actions, but I wanted to lift up some of the big ones where, you know, the direct outreach to our residents, these are literally people going out. Many of you, our community partners, have been doing this. We funded the community resilience coalitions, and I think many of you are familiar with those, which is a very large effort that we hope to sustain over time. And then, so you can see some of these. I'm not going to go through all of these. If we go to the next slide, this slide deck is going to be available, I believe, to everyone on the call. You can take these, you can look at what some of the actions are or the strategies we planned, and then look at the actions that we've taken so far. So this is in the test and isolate. And I noticed that here, you know, one of our strategies was to ensure equitable and ethical access to medication and therapy. So some of the feedback we heard at the beginning of the meeting, I think, speaks directly to that. And that's where we would definitely like to get input. Next slide. So this is one where we are looking at redressing racial ethnic health disparities. And again, some of the actions, you know, we've always from the beginning used data to drive our decision-making, looking at those with the lowest vaccination and highest transmission rates, as well as those neighborhoods that have had historical barriers to accessing health services in this county. So that, again, our focus has been to try to reduce those barriers or eliminate them to provide more equal access or equitable access. So these are things, next slide. You can see there's a lot of information. So I'm not going through every one of these bullets. I'm not going to drag everyone through that right now. And the very last one is looking at our infrastructure. And these are really some of the ways that we relate to each other, the way the county relates to our community partners, and some of the things that are going on that are really part of the core infrastructure that holds up, that enables us to get services out into the community, to the places where they're most needed. So the question I wanted to pose, and this is what the breakout groups would focus on, next slide, please, is really, we're entering into a whole new phase of the COVID pandemic. I shouldn't say new because COVID is really not predictable. It's been new all along, I guess. As we enter into this next phase, there may be reductions in funding. We talk about FEMA maybe coming to an end, the Federal Emergency Act, in the next few months or even 3 months from now. So where is it that we want to focus our resources? What are the capacities that need to be built to continue to maximize the health and to protect the health of our residents? Next slide, please. So what we're going to do right now is I'd like to see, we're going to have about 10 minutes for you to be in your small groups. I'd like people to self-select. We're going to have breakout groups, one for each of those goal areas. And I should say goal number 2, right now we don't have a facilitator for that. And so we were going to combine that with goal number 3. So if you're interested in either goal 2 or 3, you could go into group number 3. But we would like for people to self-select one of the 4 breakout groups, move into that breakout group. There's a facilitator, one of the small working group members that helped to design this process. They're going to facilitate that session. And excuse me, I have to, I have to deal with a tickle. Okay. So why don't we go ahead and do that, and they will take it from there. After about 10 minutes, we'll come back to the large group, and we're not going to summarize what happened, but we're just going to close out the meeting from there. Okay, excuse me, any questions?
Thanks, Julie. It's Lauren. I just wanted to mention, if you're interested in number 1, you just stay here in the main room. So we'll have a breakout room for 2 and 3, which are the testing, the racial and ethnic health disparities. We'll have a breakout for number 4, which was strengthening public health infrastructure. And then number 1, folks can stay in this room. And
You going in and out, Lauren. I don't know if for anyone else.
This is also where our Spanish language and we only have that choice there. But I will open the rooms. You can select.
Lauren, we're losing you a little bit. You're going in and out.
One you want to jump into. You can probably move around in it. I'm going to open the room for 10 minutes. Did you hear that?
Yes, we did.
Okay.
Maybe you can write out in the chat the instructions as well, please.
Sure will.
Thank you.
I'm not seeing the breakout room.
Okay, I'll do that quickly.
Groups
I
yet.
haven't opened them
Oh,
yet.
okay.
I was going to chat everybody.
And if you could back up one
about that.
slide for the slides, that'll show you the different goal areas, which correspond to the breakout rooms. There we go. So you can see those are the 4 goals, and excuse me, it's just 1, 2, 3, 4 straight across.
And Julie, 2 and 3 are combined, you said?
Yes, we combine those. So there'll just be 3 breakouts.
Is it possible to share this slide with the breakout? That would be very helpful.
We have the breakouts will have access to the Jamboard, which has the same information.
Very
But I can drop this in the chat too as well.
Thank you.
Okay. All right. I'm going to open the breakout rooms for about 10 minutes, and you can feel free to. Okay. Okay. Gabriela, you have what you need, and your scribe is Nancy. And
Thank you.
I can help.
And then are we putting the Jamboard up on the screen?
You are welcome to. I think we can, so people can see it. That would be great if we could spot.
I can't share my screen.
Oh no. Me.
Team,
Yes.
quick question. The first one says strengthen, align public health infrastructure. Was that the full word?
Yes.
Okay. And Gabi, if I may, test and racial ethnic health, strength, align public health. I'm trying to figure out which one I should be in. I'm sorry.
Okay. Can everyone see the screen?
Yes.
Okay. So if you chose group 1, this is the first box in that chart. So Erin, I don't know if that's the one you were looking for. So really the question here again, as we enter the new phase of COVID and the pandemic, with the potential reduction of funding, what do we need in terms of resources? And so the idea here is really to figure out from these stickies where to place them on this chart of prioritization. If there's something that's missing or maybe not stated in one of these, we can also go ahead and add. Who would like to start? Do these make sense here? Does the chart make sense?
I guess that what puzzles me is I tend to think about what's really important first, and then after that I think about what resources are available. And so this kind of requires us to think about both of those at the same time. So it's just taking a little time.
Mm-hmm. Thank you, Wendy, for sharing. So given what Wendy has shared, should we start on that piece first? Great. Does anybody want to add to the question that Wendy posed? It's a very quiet group. So maybe we can start with the first one. So it's talking about supply or link people to resources as needed. Do we feel like there's enough resources to achieve goal number 1, or is there things that are still missing?
So I feel like when it comes to supplies or link people to resources needed, like in my experience in the community, yes, people has a lot of needs, but so many of the resources that we could link them to they don't fully like are eligible for those resources. Like sometimes there's resources that really ask a lot of requirements that many of the community members that we are like, serving to or trying to connect to are not able to eligible. So I think like for that, I could say like, it's like, yes, there's a lot of high resources, but the fact that there's a really low community participations in those resources, because it's sometimes those resources are not created for the community that we're serving, like the low income community that we live in, because they have so many resources. So for me, that will go between like high resource availability but low community participation.
Great, thank you, Shirley, for sharing. Do others agree? So what I'm hearing from Shirley, that the resources may exist out there, but there may be challenges and barriers of access to these resources. So we need to figure out how can we make it more accessible is what I'm hearing Shirley say. What about others?
Yes, I agree with that. And I think accessibility, you have to really think about that in really very broad terms. It's not just the simple stuff like whether it's on the right platforms or in the right language, but also who are the carriers of the language of the message. Who are they? Trusted representatives that community members recognize and listen to.
Thank you, Wendy. So the messengers being the important piece, not just having the resource itself or the access, but also who's giving that message. Others? If not,
I can jump in, Gab. If I think I'm also I'm speak through this from the work on the commission. I'm thinking about like a lot of it is sort of contextual also, right? And so what is there's going to be like we can think of it from some demographics or geography, right? Resources. So I'm thinking about like our east end of the county, right? And where there might be a lack of available resources, right? And so, and I think that maybe it's just the way I sort of think about things, but the chart is really throwing me off with this particular point on like linking people to resources and whether there's high resources or high prioritization. It's like really messing with my brain. So I can't figure out exactly where it should go, but I'm sort of thinking about how there's that aspect of not only the messenger, the who's communicating it, but where is it located, accessibility of it, all those things, right? And thinking about what might be those pockets that we're missing within even within our communities, right? Of just where, I don't know if that's helpful at all.
Yeah, so I think what I'm hearing you say, Nestor, is not every community can be put in this box, and it's hard to kind of put everyone in this chart. And maybe this chart is not the best way to prioritize some of these things because there's different needs depending on the group itself. Great. And that's definitely some feedback we'll give for the next time. How about the support community-informed and community-led health promotion efforts? If there's less resources, what could it take to do this work? Is this something we should continue to prioritize? What about this sticky note should we be thinking about in the future?
I think it's really important. I mean, yeah.
Do you want to say more why it's important, Wendy?
Well, for the, we were talking about the last sticky and access and having members of your own community be able to inform you, with messages that are correct and not misinformation. It's critical, as well as making sure that the resources that people are pointed to are really there and that they work and that they don't encounter barriers like we were talking about at the beginning of the meeting.
And would you put it
how to do that though with low resources? I'm not really sure. I'm not really sure how to answer that question.
And so I guess maybe a different question is, in terms of like we were to look at different levels, would you put it on low, high, or medium priority of funding it if there's limited resources?
Ah.
And I'm being told that we need to come back to the group. So if you want to think about it, Wendy, it's totally okay.
I think the first two are so linked that they're both high priority and they need to go together.
Thank
I
you.
agree, Wendy.
Thank you, Nestor. Others in the last 58 seconds that would like to add to the conversation? Anything?
So I think that the aligned prevention, health promotion, education integrated with testing vaccines. So I think that should be a high, in those areas, I think it's low resourceability and low community prioritization because I feel like there's a lot of outreach or work done around it, but I feel like there's a lack of education and information that goes in it, not just because the information is there, but it's due to the language barrier that it's out there in the community that doesn't help inform enough people.
Thank you, Shirley, for sharing.
And the vaccine Alameda County residents and
Again,
work with the.
you're just mixing metaphors. It's the case method most important. People can understand that.
We're merging back into singular groups.
So I think we've all just had our Star Trek moment of being beamed out of one room and into another.
Stated. As everyone repopulates, and I'm not sure if other groups had this problem, I'd love to just jump in. So in the explanation of the process, the difficulty became where are mid-level placements of ideas, right? So do we need to broaden the 4 quadrants into 6, having high, mid, and then low, as far as the decision-making process? And then there was also the discussion, the question, how are we defining it? Is the high resource availability something that is easily obtainable and implemented, or is that low resources? We need low resources to implement it, and it's a high community prioritization. So I think if we define those that all groups are in alignment and are implementing the strategy similarly, it would be very beneficial. I don't know
Thanks.
if other groups had that difficulty.
Thanks, Gary. That's helpful. I think I see a thumbs up from Gabriela, and I think there might be a little bit of retooling that we might have to do, and we're at 7 o'clock, and I just want to make sure that I'm respecting everyone's time. And so what I'm gonna suggest is that we that those who were coordinating leading groups bring back that valuable info to folks like Julie and others, so that we can think about that. But I think the conversation has started, and that with some of those adjustments and maybe clarifying and defining some of those things, that there will be some, I think, very good information that sort of comes out of this process. So, but I do want to respect everyone's time, because it is 7 o'clock, and I know folks, might want to go have dinner and spend time with family and loved ones. So I will I will begin to wrap us up and thank everyone for your participation tonight, especially those of you who provided really great feedback to us and information. That is I think super key, a really important piece of this group. And so I want to encourage those of us who haven't had a chance to provide some of that key information feedback to do so, right, at our next meeting, or through email, or by contacting some of the folks here in this group. So thank you again for choosing to spend your evening with us. I look forward to our next meeting. Stay safe and have a great rest of your day and rest of your week.
Good night, everyone.
Peace and blessings.